Hello, and welcome back to my house. Thanks for coming in for another day of flexible learning. We're going to do a quick review. We will start with a review of what we've gone over so far in the first 2 days of the knee. Remember, there are 4 bones. The femur, the tibia, the fibula, and the patella are the 4 bones that make up the knee joint. We have the tibiofemoral joint, where the tibia meets the fibula, or the femur. We have the patellofemoral joint, where the patella rides in the trochlear groove of the femur. We have cartilage. We have medial meniscus and we have lateral meniscus. Medial on the inside of the set on the tibia. The lateral meniscus sets on top of the tibial plateau on the outside or the lateral side. We also have articular cartilage in the joint. We have the MCL, which runs on the inside of the knee, and we have the LCL, which runs on the lateral side of the knee. Next slide. ACL, anterior cruciate ligament. Anterior cruciate ligament runs from the front or the anterior portion of the tibia to the lateral side of the femur, and the posterior cruciate ligament runs opposite of that. It runs this way. Next slide review, the quadriceps. There's 4 muscles of the quadriceps that you need, they need to sound familiar to, but the vastus medialis oblique, which is on the inside. We have the vastus lateralis, the vastus intermedialis, and then the deep, the rectus femoris that we cannot palpate or feel. Quadriceps, again, aid in knee extension. Hamstrings assist in knee flexion, consists of the semitendinosus, the semimembranosus, and the bicep femoris, all aid in knee flexion. Injuries, we talked about, I've had some experience. We talked about the O'Donoghue's terrible triad, which is a torn MCL, torn meniscus, and torn ACL, are the 3 things in that terrible triad. Talked about MCL sprains. We did MCL testing, which is a valgus stress test. Meniscus tear, we talked quite extensively about meniscus tears and the red flags, the swelling, pain, locking, and giving way of the knee. Ways that we can assess meniscal tears without an MRI is the Thessaly test and the McMurray test. Different types of meniscus tears. Some scope pictures. This is a bucket handle tear. You can kind of see how that looks like a bucket handle. Anterior and posterior root tears. This is where the meniscus attaches into the tibial plateau part of it. It's called the root. Talk about treatment options. We went through what a meniscus transplant would look like. These are some pictures of meniscus transplant. ACL tear, mechanism of injury, is that plant and turn that we've all heard about. ACL, a very common injury. Who's at risk? We talk about anybody playing a sport that requires shifting or changing motion quickly. Talk about females being more likely, or 8 times more likely than men, to tear their ACL. And some reasons why were a decreased intercondylar notch or an increased tibial plateau slope. Signs and symptoms of an ACL tear. A pop is heard, there's swelling, restricted motion. Testing and diagnosis, first thing they're going to do, they're going to do x-rays to make sure that no bones are broken. Then they'll do an MRI to look for soft tissue injuries like ACL, PCL. A couple of pictures of this is a torn ACL. This is a non-functional ACL with a lot of laxity. It doesn't work. This is what an ACL repair looks like. This is an internal brace on this one that you can see on those 2. This is without an internal brace, and this one is not looking so good. ACL testing, we have slide test and we have pivot test. A slide test is where they try to get the tibia to slide anteriorly on the femur. Slide test, we have the Lockman test and the anterior drawer test, or the 2 slide tests, and then we have the pivot shift test. I believe we ended with the pivot shift test at the end of the last video. I think we got cut off a little bit short. Starting with our notes for today, ACL treatment options. Some people are going to choose, if they have a desk job or something they're not real active in doing on a daily basis, they may choose to just do physical therapy and not have surgery, just to try to regain some muscular strength around with the quads, the hamstrings, the gastrocnemius, and the calf muscles there. If you do decide to proceed with surgery, because we want to be active, you want to be able to do things in life, you have 2 options. There are autografts and there are allografts. An autograft comes from that person, and the options would be patellar tendon, hamstring tendon, or quad tendon. And the other allograft would come from a cadaver. ACL surgery. This is a bone. We're going to watch a bone-to-bone patellar tendon graft surgery here. I believe it's about 3-4 minutes long.
The graft that is taken from the middle third of the patella tendon is about 10 centimeters long. It incorporates a plug of bone from the lower part of the kneecap on one end and a piece of bone from the upper tibia on the other end. The defect in the patella tendon is closed. The tendon heals and eventually regains its strength. This graft can also be taken from a cadaver. This has some advantages, but also some risks. The rest of the operation is performed with the aid of the arthroscope while viewing the inside of the knee on a television monitor. The arthroscope is introduced into the knee and the joint is inspected. Any associated problems such as torn cartilage is corrected. To create a tunnel in the proper location in the tibia, a guide pin is passed through the upper tibia. It enters the joint at the spot where the ACL normally attaches to the tibia. The guide pin is over-drilled with a cannulated drill. A guide pin is now passed through the tibia tunnel and into the femur. It is drilled into the bone at the spot where the ACL normally attaches to the femur. The pin is over-drilled to the appropriate depth. A long guide pin is now passed upward through the tibial tunnel, across the joint, into the femoral tunnel, and out through the front of the thigh. This guide pin is used to pull the ACL graft through the tibial tunnel, across a joint, and into the femoral tunnel. The knee is fully flexed. Working now through a small opening in front of the knee, a guide pin is pushed into the femoral tunnel next to the graft. An interference screw is passed over the pin and screwed into the femoral tunnel. This secures the upper end of the graft in the femoral tunnel. The knee is now extended and the graft is pulled tightly. As tension is applied to the graft, a second interference screw is screwed into the tibial tunnel. This locks into place the lower end of the graft within the tibial tunnel.
Also use buttons here and then
the
up on the femur
screws
as well.
securely hold the new ACL in place until the bone plugs heal in place. The knee is now stable and motion can begin immediately. In fact, a continuous passive motion machine, or CPM, is used to slowly move the knee about 23 hours a day. This early and continuous motion is very important to decrease knee pain, to quickly regain knee motion, and to avoid problems with the kneecap.
All right, after the ACL surgery, what does physical therapy look like? Oftentimes it is 6 to 9, 10, maybe even 12 months of physical therapy going 2 to 3 times a week. As some examples here, this is blood flow restriction, these two pictures here and this over here. Blood flow restriction is also called BFR, and what it does, this is like a tourniquet or a blood pressure cuff that gets tight and it cuts off some of the blood flow to the lower limb, or if they use it on the arm as well for rehab. And then you do exercise like quad sets where you tighten the quad and then release, tighten the quad and then release, or leg raises would be other things they'll do. This is dry needling. Remember we talked about STEM at the beginning of the year and how it's just an electrical impulse that is sent in through some pads. The only difference is here, these are needles that are stuck into different parts of the quad. and then the stem, the stem electrical stimulation goes through those needles. I found that to be pretty uncomfortable. BFR is difficult; it wears you out really quickly. Range of motion is something that's very important after any type of a knee surgery. The first thing that your doctor is going to want to do, one of your first goals, is to get full extension. When the patient doesn't reach full extension, they may be put in a Jazz brace. Jazz is just a brand, but it is a brace that works on extension. So this person's knee, that would be as straight as they could get their knee. There's a dial here that they turn that. You do this 3 times a day, 30 minutes a day, and every 5 minutes you crank it to try to extend the leg further. Regain full motion. Also, the next thing after they have full extension, you want to regain full flexion. So if I was 0 to 150 before surgery, they would try to get 0 to 150 back after surgery. If you cannot get full flexion, something they do, this is another Jazz. Jazz is just the brand, a Jazz brace, but 30 minutes a day, 30 minutes a session, 3 times a day, you would sit in this. So this is the most flexion that I had there. And then there's a dial over on the other side. You can see it here. You crank the dial every 5 minutes, and it's pretty uncomfortable. It was not comfortable at all to do that whenever flexion is painful for you. So that's what happens when you are not meeting goals. They have these other devices that they're going to use. Oftentimes it can be scar tissue that's preventing the joint from moving through its full range of motion. Mine, in my case, was I had articular cartilage damage, which those bones were just grinding against each other and causing pain. They also do something called a manual manipulation under anesthesia, or MUA. Also a lysis of adhesions, where they go and take out the scar tissue, would be some things that they would do to help in that knee range of motion. Next thing, return to play. Return to play after an ACL injury. The first week, just trying to diminish the pain and swelling. Week 2, they want to get full extension. Remember I said that's one of the first things. We're going to work on flexion here, maybe some walking, strength training, and jogging. Around 12 weeks is oftentimes when the physician will allow you to start jogging if everything is going well. 4 to 7 months, you can do a few activities, light activities, not soccer or football or anything like that. And then at 8 months, they may let you return to full activity, depending on where you're at in physical therapy. ACL tear prevention. There's a lot of prevention programs out there. Most of them, they're just neuromuscular training programs. They're also, especially the ones that are made for females, want us to work on landing correctly. So jumping and landing in that deep knee bend, not staying high with our legs, with our knees straight. Hamstring strengthening, quadricep strengthening, and agility, changing of directions are all big pieces in all of the ACL tear prevention programs, but there are many out there. What are the risks of re-injury? Well, I put my MRI results up here, but a right knee pain and instability with failed ACL, so it does happen. It's pretty rare. About 5% of ACL tears and ACL surgeries will re-rupture that same leg. You are at greater risk of injury on the contralateral leg. So since my right leg is the knee that I had surgery on, I am at greater risk of tearing my ACL on my left leg than to re-tear on the right. But like I said, it does happen. Factors that increase your risk, what you do affects your risk. So if you're playing sports like soccer, basketball, skiing, and you're not strength training, you have maybe a loose joint by nature. I want you to try this right now. Take your hand, take your thumb, and pull it down towards your forearm like that. And if you can reach your thumb to your forearm, you have probably by nature, just your joints are a little bit more lax. A lot of athletes do have more lax joints than maybe some that are not athletes. Check that out. See if you can reach your thumb to your forearm. Patellofemoral problems. These are sometimes hard to identify as the problem. This can be pain in the front of the knee. So patellofemoral, let me move this for a minute. This is the femur, this is the patella. Remember the trochlear groove? The patella rides on the trochlear groove here. It's kind of like a slide. If it gets up on the side here, then that's uncomfortable. That can become painful. And you can see here it's rubbing on the back of the patella. So that would be patellofemoral problem. Patellofemoral problem. Pain on the front of the knee, crepitus, which is a grinding noise. The treatment for patellofemoral problems would be shoe inserts, taping the arch, strengthening, different types of bracing and taping of the patella. Patellofemoral problems, again, there's no ligaments that hold the patella in place. We know we have the quad tendon, we have the patellar tendon that attach into the bones, and those are tendons, but no ligaments there. Talked about how the patella rides on the trochlear groove. It's like a slide. We want to keep it right in the middle. You do not want to go up on the sides of the slide, or what happens, if you can see in this picture here, that there's the grinding away of the femur and the back of the patella there. It's painful. This is a painful condition. A high Q angle can lead to patellofemoral problems as well. We're going to look at Q angle here. What is a Q angle? Females have a greater Q angle oftentimes than men, and you can see that is because the wider hips that females have, it increases the Q angle right here. So it almost looks like it's knock knee, is that Q angle there. What other pictures here? We have an inward or valgus tilt. Increased risk of ACL. A higher Q angle is going to increase your risk of ACL injuries. This person here is knock-kneed or has a greater Q angle. This is the bow legs, which we might talk about here in a minute. There it shows the Q angle here. That is how you measure a Q angle if that were an x-ray. Some of you had Coach Schneider when you were at Heritage Middle School. These are Coach Schneider's knees. And this is when he was 34 years old. This is from several conditions. The doctors will look at the x-ray and think that this is an x-ray of an 80-year-old man's knees. So kind of what happened here, wear and tear from years of athletics. He was knock-kneed to begin with, and this has worn down the lateral meniscus. So knock-kneed means that your knees are turned in with that greater Q angle. And when that is turned in, you can see here the lateral meniscus is going to get pinched right there. And then there's space here. There's gapping on the inside. Something they can do to correct knock-kneed or bow-leggedness is called a knee osteotomy. They can do this. They can do a high tibial osteotomy, or they can do a distal femur osteotomy. Osteotomy just means cutting of a bone. It's used to correct valgus or varus alignment in the knee. They have something called the open wedge or closed wedge. So what they would do, they would go in and they would cut an angle like a wedge out, and that would be closing wedge. Or they can go in and cut one slit in and then insert wedge like they did to my knee in January, or to my tibia in January, and then they're going to push that angle out. This can be done before arthritis, or should be done before arthritis progresses. It gets too high of a grade. You can see here again that meniscus is being crushed and worn down right here, so it's not going to be functional anymore. This is alignment. Right down the middle would be at this 50% line whenever they're planning for a high tibial osteotomy or a distal femoral osteotomy. They are going to decide where they want your weight to go. So the neutral alignment would be right down the middle. And they're shifting this out to the lateral side just a little bit. So this person has had trouble with their medial meniscus, and they want to shift the weight to the outside if they're moving the axis point there. Picture here, this would be the normal knee. This would be a diseased with arthritis knee. You can see the collapse on the inside, the medial side here. So that meniscus is probably being crushed. I think this is actually a picture of my knees. This is my right leg, and you can see how the meniscus, you can see the tissue there on the x-ray that's pushed out, the meniscus pushed out there. High tibial osteotomy, this is a quick video.
High tibial osteotomy is a technique designed to correct pre-arthritic and arthritic deformities of the knee. The alignment of the tibia, or leg bone, is adjusted to shift the stress of weight bearing away from arthritic areas to healthy cartilage. This technique provides an alternative to knee replacement. The surgeon begins by measuring the amount of deformity of the knee on X-ray and determining the amount of correction needed. The correction angle is the amount the tibia must be opened to shift the weight-bearing axis of the knee to healthy cartilage. Once the correction angle is determined, the surgeon anatomically aligns the iBalance HTO instrumentation to the patient's tibia through the use of X-ray.
So lining up, they call this a jig that allows them, it shows them where to cut for high tibial osteotomy.
The instrumentation is then fixed into place utilizing two fixation pins. The first fixation pin is placed through the hole
They're
in the
showing us
front of
an
the
open
instrumentation.
wedge high tibial osteotomy. So they're going to cut a slit, and then they're going to
And the
insert
second
wedges
fixation
in to
pin is
change the
secured through the
alignment of
hole
the
on the
knee.
inside part of the instrumentation. The surgeon drills a hole at the end point of the osteotomy, enabling the placement of the hinge pin. Which is fixed into place with the collet nut.
So now they've got the jig put on the
Then,
tibia.
in a stepwise fashion, keyholes are reamed to chamfer the bone for the entry of the cutting guide. The vascular shield is placed behind the tibia and secured onto the cutting guide.
High tibial osteotomy can be used if there's
Once
arthritis.
the safety envelope is confirmed,
On the inside
the
of the
surgeon
knee
will
as well,
complete the osteotomy with a
arthritis later.
sagittal saw.
That's the cut of the tibia, and now they're going
The
to put
instrumentation
wedges.
is then removed to prepare the osteotomy for fixation.
It's going to open the wedge.
The opening jack is inserted into the osteotomy, and in a controlled manner, the ends of the osteotomy are distracted until the correction angle is maintained.
So
A
the
bone
tibia is
graft
still
substitute,
connected
soaked in
on this side
platelet-rich
here. It's
plasma,
just a wedge
is
cut
placed
out.
through the gap in the opening jack for structural support and to enhance bone formation. The implant is then placed through the same gap inside the osteotomy, and the opening jack is removed. A drill is used to place a screw through the plate to hold the implant in place.
Going to secure it with 4 screws, peak screws, which are plastic. These are plastic. They have something on the end where you can see where the tip is on x-ray.
All
I'll show
4
you some
holes on the
x-rays
plate
in a
are
minute.
filled with screws to secure the implant.
Then they fill it with the bone matrix and sew it up after that. I have a few pictures here. These are x-rays in the surgery. This is their rod that's looking for alignment. They go from the center of the ball and socket, from the acetabulum there, from down to the ankle. So these 2 pictures, x-rays, could be lined up. And this is where the rod, after the high tibial osteotomy, see they're opening there, the opening wedge. So now it doesn't run through the middle or the middle here, but almost through the outside. So the weight will be shifted more to the outside of the knee. A couple more pictures. This is what it looks like when it is done. This is the osteotomy. This is the bone. You can kind of see on here the black piece, the little black tips. Those are the tips of the 4 plastic screws that are put in. This is a 6-week follow-up on high tibial osteotomy. You can still see this time they're white, the tips of the screws. This is the implant here, and this is an implant here. All right, we will start tomorrow with patella dislocation. I hope you have a great day. Get outside and enjoy the weather if it's nice today.